The choroid is the most vascular tissue in human body, and its imaging has always been changing. The role of choroid in pathogenesis of retinal disorder is being increasingly clarified. This is the choroidal tissue this is the posterior aspect of choroidal tissue after removal sclera. So you can see highly vascularized tissue under electron microscope. And this is choroidal tissue, and you can see by indocyanine green angiogram, you can see even these are the vortex vein for vortex vein. The other important point is the development of technology of OCT. The OCT is increasingly become more efficient in choroidal imaging, especially the modernist one, which is the swift source OCT. So this is the spectral domain OCT. And as you see here, you cannot see the interface between the choroidal tissue and sclera. And then by more advancing technology, by enhanced imaging technique of spectral domain, still there is a well-defined interface between choroidal tissue and sclera. But by this generation of OCT, which is swift source OCT, you can see this line which demarcates the interface between choroidal tissue and sclera. So in this study we are using this type of OCT. Cscr is a very common disease regarding retinal diseases, and it is the fourth most common medical retinal disorder after diabetic retinopathy and central retinal vein occlusion and age-related macular degeneration. And the whole theory about Cscr, as you know, is usually concerning the retina. There is defect in the retinal pigment epithelium and collection of fluid in subretinal space. But later on, they focusing on the state of choroidal vasculature as pathogenesis for Cscr, and even the name is changed from CSR into Cscr because there is focusing on choroidal vasculature. This is by ultra-wide field indocyanine green angiogram. This is the choroidal tissue of normal person, and this is the choroidal tissue in patient with active CSR. But as you know, the indocyanine green is an invasive method, and even the fluorescein angiography is an invasive method, and we are searching for non-invasive method and more accurate method. So the major advantage of OCT is a non-invasive, and we have many advantages of we have advantages especially in pregnancy and allergic patient, difficult venous access, and in ill patients, where the fluorescein angiography and indocyanine green is difficult or even contraindicated. The aim of this study was to measure the choroidal thickness in eyes with active Cscr and to compare the thickness with contralateral eye of the same patient and choroidal thickness in normal healthy persons as a control. This is a case control study. It was conducted in Medical City. Patients were diagnosed as usual by clinical examination, and we sent them for OCT to find the collection of fluid in submacular area. And we exclude any ophthalmic or systemic diseases that might interfere with vasculature of choroid, for example, uncontrolled hypertension, diabetes, glaucoma, uveitis, high refractive errors, intraocular surgery. All these cases are excluded from our study. The study is performed by SSOCT dope on triton, and the results were displayed in an ETDRS style map. So this map is not retinal map as usual. This is a choroidal map. This is a choroidal map. So you can see this is the subfoveal area. Here is the macular thickness in subfoveal area, and this is the macula, superior macula, inferior, nasal, temporal, inner macula, and outer macula. So we have 9 areas to be assessed by OCT choroidal thickness. This study enrolled 49 participants, which includes 16 patients with Cscr and 33 patients control. We took both eyes from patient with Cscr and one eye from each control patient. So we divided our patient into group A, B, C. Group A, we have 20 eyes with active Cscr, and the contralateral eye is only 12 because we have 4 patients having bilateral active Cscr, and 33 eyes one eye from each patient with control. So you can see here that our sample is matched regarding age, gender, body mass index, and spherical abrasion. You can see the p-value is not significant. So there is no difference regarding all these parameters between patients and control patient. The thickness for group A with active disease is 474, which is nearly equal to the contralateral eye. Here there is no symptoms, but although there is similar thickness of the active disease, while here there is a decrease in thickness or normal thickness of choroidal tissue. So the thickness in patient with Cscr in both eyes, the active disease and the other eye. As you know, the disease usually involving one eye, and only 30% and some percentage, maybe 14% involving both eyes. So there is statistically significant difference between choroidal thickness in all sectors. I mean the 9 sectors of macular area. If we compare the group A with the group C or group B with the group C, regarding all 9 areas, so you can see there is thickness, and if you compare group A with the group C, which is normal, there is statistically significant difference. and even between group B and group C. Also, there is statistically significant in choroidal thickness, but there is no statistically difference between the eye with active disease and the contralateral eye. This is one of our patient, normal person. This is the mapping for choroidal thickness, and you can see there is a well-demarcated line between sclera and choroid. This is not manual drawing, this is automated drawing by the machine itself. And it can measure the thickness of choroidal tissue. This is normal person, and this is the normal thickness in 9 layers of macular area. This is one patient with diseased eye. This is active Cscr, and this is the contralateral eye. And you can see even in contralateral eye there is an increase in thickness of choroidal tissue. Many studies goes with our results, but few studies suggested that the thickness of choroid is increased only in active disease and the contralateral eye thickness is normal. And really we have no explanation because still the pathogenesis of Cscr is still unknown. So this study concludes that choroidal thickness is significantly increased in both eyes in patients with active Cscr, and we need future work is required to explore the pathogenesis.